Today, I get the privilege of interviewing Rachel Marsiglio. She is the third of our series in this concept of healthy eating, body image, and eating disorders. So, Rachel is the owner of a company called Nourish to Flourish, and she has other dietitians and nutritionists working with her. But Rachel herself is a registered dietitian. She is a certified diabetes care and education specialist and a certified eating disorder specialist. I think she's got a pretty interesting view on things. So today we are about to learn from Rachel. Rachel, is there anything you would like our audience to know about you before we get going?
Not that I can think of. Thanks for joining, everybody. Thanks for listening.
So many questions. And as you know, we interviewed David Rogers, who we both know and admire, and his approach to treating clients with eating disorders. So, what makes someone an eating disorder registered dietitian?
So, to consider yourself an eating disorder registered dietitian, it does come with extra trainings per se. All registered dietitians go to uh, school to college and get an undergrad degree. And now it's required for a master's degree in order to become a dietitian, and then do an internship. And after that is when the real fun, the real training kind of starts once you are a registered dietitian by doing trainings or CEU events or other educational type stuff. It might be also working with a mentor. When I first joined the field of private practice, I found the dietitian in the community that had the most experience. I reached out to her and I said, "Will you help me?" And I spent a couple years with her going over cases every month or even twice a month in order to truly gain that knowledge and that expertise. So it does take time after someone becomes a dietitian in order to get that experience. It might also be on the job experience working with other dietitians in a higher level of care type center to be able to get that experience.
Right, which is it's good, right? When you are being trusted to treat folks and to have the experience level and to have been through your own, journey of learning. As a counselor, this is a population that I'm cautious with because it can be a deadly disorder. So having the background that you have is just impressive. So what is the difference between somebody who is an eating disorder dietitian and a certified eating disorder specialist?
So the Certified Eating Disorder Specialist is a certification through IADEP, which is the International Association of Eating Disorder Professionals, and there's many requirements to be met, including a minimum of 2,500 hours of eating disorder experience. It also requires 24 hours of consultation provided by an IADEP approved consultant and completing 4 core courses. Each course is worth 3 CEUs, and then requiring once you are able to earn that certification. So all those hours, and the hours need to be accrued over at least a 2-year period. After that, and you're able to earn it, then it's continuing with the CEUs every 20 CEUs every 2 years. So there's a lot of time and money that goes into earning that certification.
So, what drew you into this field in the first place, Rachel?
So I had an aunt, my dad's sister, who died from complications of obesity. And as an adult and as an eating disorder specialist, I've been thinking about it more. And she actually started to gain weight after her father passed away. And I don't know for sure, but I'm guessing that there was some type of eating disorder there. And it's just always been something that's been so interesting to me.
So often, when people think about an eating disorder, their minds go to anorexia or bulimia. But what you're talking about too is an overeating disorder. Yeah.
Yep. Yep. There's also binge eating disorder where people may binge on food, and that's this feeling of being out of control and eating a large amount of food over a short period of time. So that also happens. And then there's also another one called ARFID, which is acute food refusal intake disorder. And a lot of times that deals with textures or sensory type things.
Okay. So, your primary population, what would you say most of your clients are suffering from?
It's a combination. I have some clients with anorexia, some clients with bulimia, some clients with binge eating disorder, some with ARFID. I get a mixture of it all. I've found as I've been in this career now in private practice for 10 years that I have a preference towards towards individuals in their 20s, 30s, 40s, 50s, 60s, a little bit older. But I still work with kiddos and teenagers, and I currently have them on my caseload.
So, what are the ways that a registered dietitian can even help clients with eating disorders?
That's a great question. So there is the traditional way where everything is individualized too for that person. The goal may be normalized eating or intuitive eating, a reduction of eating disorder behaviors. There may be a goal weight to gain weight to a healthy weight if the person's underweight. That may also be a part in there. The traditional way typically is more of a top down approach. So there's mainly talking and trying to change thoughts around food or around body and more. With new clients, we always want to check their medical stability. And this means going to the doctor and possibly having labs done, so blood drawn and labs done, checking vitals and possibly an EKG. There's a lot of education that's done. Some examples are things to expect during the renourishment process or the effects of restriction on the brain and body, the restrict and binge cycles or macronutrients. So there's lots of education that we do throughout the time. With the traditional way, there's typically a meal plan that's provided to the individual. And we like to meet at Nourish to Flourish, we like to meet clients where they're at. So we may take what they're currently eating and then based upon our assessment of that, add food to a particular meal or increase the portions of what they're eating or focus on getting more food groups in. It's typically about this meal plan though, and getting them to eat more normalized, more intuitively. We may use therapeutic strategies such as reframing thoughts or urge surfing, journaling, or delaying a certain behavior. And so those are some examples of the traditional way.
Okay. But as a dietitian, you aren't necessarily getting into the causes of the eating disorder. You are more focusing on how to treat it. Yeah.
For the traditional way, yes. Yes.
Okay. All
Our
right.
clients come to us with a problem and we're expected to fix it, is the best way that I can think of saying it. And we typically stick with this idea of meal plan and food and exercise, and the rest of everything kind of goes more towards the therapist. There is a lot of overlap that happens between the therapist and the dietitian, especially with the certified eating disorder specialist, but there is a lot of overlap that can happen too.
Okay. So explain the differences between the different types. And so if you're talking about your traditional versus maybe the way that you approach things, or, in particular, the difference between a certified eating disorder specialist or a certified eating disorder specialist therapist and a certified eating disorder specialist dietitian. Am I
So
saying that right?
yeah, yeah. It used to be
Okay.
separated where the therapist was a certified eating disorder specialist and the dietitian was a certified eating disorders registered dietitian. But a couple years ago, they changed it and everybody's just seeds now, is what they say.
Seeds, okay.
Yep.
And so these are the things people need to look for when they're looking for a dietitian, yeah?
Yeah, finding a seeds would mean that they've gone above and beyond with their training and their education. It's not a necessary thing, though. There are some individuals out in the community that have been working with eating disorders for 10, 20 years, just never did the seeds certification. And I would still trust to recommend or refer a client to a therapist or to another dietitian if for whatever reason I wasn't going to work with them. There are individuals in the community that I would feel comfortable with referring to without the seeds. It's just the seeds is the certified specialist.
Okay. So when a new client comes to see you, what can they expect? What's the first session look like? And are they typically referred by a therapist?
They may be referred by a therapist or their doctor. Sometimes a parent's concerns. Sometimes a parent may have had eating disorder themselves in their younger years and they're seeing some stuff in their kids and they're concerned about it. So, and sometimes we have clients that come into us for, I don't know, for diabetes management or for high cholesterol. And upon doing the assessment, it turns out that they have an eating disorder or disordered eating. So it's very interesting because we never know what's going to show up in our office. And so we just kind of we treat everybody the same and we take a very trauma informed approach. We take things very slowly with clients. We'll take that first session, which is typically an hour long, to just get intake information, to just get to know them. For me and the clients that I see, the intake normally is at least 2 sessions, if not 3, if not more. because we really just go slowly, we go in depth because I want to know this person from pretty much from pregnancy when they were in their mom's stomach until their current daily life. And so there's just lots to cover.
What are you looking for in that assessment?
I'm just getting a detailed history about, for example, the pregnancy experience, the birthing experience. Was there a traumatic birth? Anything stand out in the first a couple of years of life that could have caused any issues? What was their experience like as a elementary school kiddo? What was the relationship like with their family and eating? Their parents' relationship with their body and food. Their parents' take on their body and food. The parents make a lot of comments to this individual about their body, or either negative or positive, just kind of hearing what their lived experience has been. Did they have any traumatic moments that stand out that could have caused this eating disorder to develop? So there's so much, and sometimes for individuals too, it may start off as one thing. Let's say in middle school, it could have started off as dieting and ended up turning into anorexia, but another traumatic moment happened in high school and their eating disorder actually morphed into more of a different kind. And then if other traumatic moments happen, then it could also continue to kind of ebb and flow and change. And so, yeah, just taking that time to truly get to know what their lived experience has been in their body.
Yeah. I appreciate that you take a trauma-informed approach. We just talk a lot about this on this podcast, is trauma-informed. It's become such a popular word in our field. But, when you're treating people with eating disorders, are you seeing a high correlation in eating disorders and trauma?
Yes, absolutely. Absolutely. So the way that I actually practice, last year, after being in private practice for 9 years, and I was at that point had been a certified eating disorder specialist for about 6 years, it became clear to me that the way I was doing stuff was just wasn't working. I felt like I was talking at people. We would have great sessions and just really good connection, really good, okay, this is the goal that we're going to set. And it seemed like even if they wrote it down, as soon as they left my office, it left their brain. And they would come back the next week and be like, yeah, we had that goal, didn't we? I didn't do it. And I would see that time after time after time again. Now, with teenagers and kiddos, sometimes, or depending on their situation, they would come back and yes, they had achieved a meal plan change, but a lot of times it was because the parent was in charge of the meal plan. But especially with adults, and there was adults that I had been working with for 5 years and just nothing was working. It was something so much more than just this is what you need to eat. So I came across this different lens. It's called Embodied Recovery for Eating Disorders. And this has forever changed the way that I work with clients, and it's also personally changed my life too. So Embodied Recovery for Eating Disorders is a bottom up and a top down process. And bottom up meaning that there's work in the body, that the body holds on to some of these traumatic memories too. But this lens views eating disorder behaviors as an expression of an adaptation that the body had to make when safety was not available. Clients use eating disorder behaviors to respond to a sense of threat or danger as if it is happening now. Yet, the body responses are oriented to the past. So thinking of eating disorder behaviors as reenactments of burdened or traumatized parts that are responding to a sense of threat or danger as if it's happening in front of them in current time. So as dietitians, we can help bridge the connection between past experiences and how they are played out with food now. Over time, we aim to give clients the felt sense of safety in the now time and updating the past parts to the present so they can come out of the pattern. Our therapeutic relationship with clients is very important, and we start from a place of yield. Yield is a developmental task, and it's the developmental task of belonging, specifically unconditional belonging. It's this idea that I don't have to do anything to be in relationship with another. And an example of this is just thinking of a newborn baby in mom's arms. And this is not true for all newborn babies. Some newborn babies don't have this experience, but a newborn baby laying in mom's arms and mom just loving on it. That baby doesn't need to do anything to receive mom's love. And this is where we start with clients. Throughout this concept of yielding, we are working to build insight and helping clients see how their behaviors reflect their past experiences. We are bridging the current day food behaviors with past experiences. So in the beginning, when we're sitting at this place of yield, we're just building rapport. We're just truly getting to know each other. And I'm trying to model to the clients that they don't need to do anything to be in relationship with me, that by showing up, they don't have to talk. Just by showing up, that's enough. And it's a different experience. And I say this to clients too, and some of them just can't even comprehend this idea because most of their experiences in life, they've had to work to perform to get any type of attention. So with Embodied, just a little snippet about embodied recovery for eating disorders, we take a look at 3 different systems: our sensory processing system, our attachment system, and defense systems. So our sensory systems send information to our brain about the world outside of us and inside of us. And sensory processing is how we integrate this information. Our attachment systems are all about safety. It is having connection with resources that provide a sense of safety, nourishment, and connection. And all that is unconditional. And then the defense is all about danger. Can I disconnect from sources of danger? Or for some, the sources of attachment are the sources of danger. So when any of those systems are profoundly disturbed early in life is when we're most likely to see the presentation of an eating disorder or compulsive exercise, body dysmorphia, the dislike of feeling of food in the stomach, and stuff like that. It's important to remember, though, that it depends on one's inherent level of sensitivity or the way one's nervous system was made. Because 2 people can experience the exact same event, and one person may develop PTSD and the other may not. So it's about their innate wiring. And it could come down to just sensory differences or even one's energetic sensitivity. And we could possibly even be intergenerational traumas. So, and I can give you an example of this too, if you'd like.
I would love that.
So one adaptation, that's a hard word to say. It's called sensitive withdrawn. So this one typically develops somewhere between conception and 6 months of age. And so for an example of this is that when a baby is born into the world, what they experience is just too much for their nervous system. It could be being born into New York City and the lights and the sounds and the smells are too much for them. It could also be being born into a family with an alcoholic. I'm sorry, let me back up. Being born into a family with a mom that's just, or family members that are just very loud. And this person just can't handle the sounds. So what happens is that they're born into this world that's just too much for them. So they withdraw up into their body container. So they aren't able to actually expand down into all of their body container and be able to embody that. It's like they can only live in a tiny sliver in the middle of their body or just up in their head. So when that happens, a lot of times people may experience body dysmorphia. It's like what they see in the mirror is different than what we see in the mirror. And that's because they're withdrawn into their body container. So that's just one example of something, of an adaptation that can happen. And another just quick example with this is a baby that's born via emergency C-section. So they're yielding in mom's stomach. They're chilling. They're just relaxed and not having to do anything. And then all of a sudden they're being yanked out of mom and being rushed off to the NICU. And they're away from the only thing that they've ever known and getting probed and probbed with all these things. And that can be very traumatic for that baby, and they can for some babies, they will withdraw into their body container because it's safer there. It's not safe in the outside world because that's their first experience in the outside world.
As a trauma therapist myself, I mean, we're speaking very similar languages. You're using the polyvagal, you're using understanding of all of this attachment systems and parts. And, this is the stuff we get into with EMDR and trauma and ego state and internal family systems. And I love what I'm hearing. But one I want to start with is you're not saying anything about body image. And I think That's interesting. And so under this approach is the theoretical underpinning it's that this is really more of a response to the past than it is about current day body image?
Yes. Yep.
That's
Um,
profound.
yeah, yep. And what I've actually found with body image is that the more somebody is in a dysregulated state, the worse their body image is. And yeah, and also just from the internal family systems lens, if they're blended with a certain part, that they could be viewing their body from that standpoint too.
So you are doing a little bit of psychotherapy here. I mean, you are really bringing the past into the present in a way that to me is out of the box for a dietitian. And this is fabulous because this is probably marries well to other therapies that your clients are doing. Of course, as trauma therapists, we here would say very little of our current day behaviors is about the current day. And so this again just resonates a lot with the way we perceive our clients and their current symptomatology. And so when you say they're reenacting, so give me an example of what that would mean. Let's just say for anorexia, because again, that's people most familiar with that. So what might somebody be reenacting?
That is a very good question. So with yielding, they could have an attachment injury, approval contingent on high productivity and performance. So they may only get mom or dad's love if they are high productivity performance, doing everything just so perfectly. They learn that they need to continue this in order to get any type of positive reinforcement, any type of attachment from their parents. And so they can't stop. They're just go. Always got to do it. And this could turn out in compulsive exercise. This not being able to stop exercising because I always have to keep going. I have to always be doing something. I have to be the best at everything like that.
Okay, so if I am only accepted for high performance and being the best, how does that translate into I will refuse food? Is it control?
It might not be exactly I will control food. There might be other survival adaptations that happen more for that food aspect. When our approval is contingent on high productivity and performance, and this idea that I've always got to be performing in order to get any type of attachment. For some individuals, they may struggle with this idea of rest and digest. So we just finished our meal and we're gonna let it just kind of sit. For this individual, they can't just sit. They have to be producing, they have to be doing something. And so a lot of times they experience discomfort in their stomach after a meal, a lot of guilt. And to go back to that discomfort after a meal, they may not like the sensation of food in their stomach. Because when we're feeling this full feeling, it's like a lot of times the parasympathetic nervous system sets in order for us to rest and digest. But this individual needs to stay more in that sympathetic state of mobilized energy of go. And so the idea of just sitting with food in our stomach, it's like, no, that's not safe.
You know, again, you're going back to the basics of belonging, which is what I hear with this approach of yielding, is the necessity of humans is we need to belong. And I believe that Dave said that in our interview was that that is such the root of so much that he sees is just belonging. And as you say, just to show up. You don't have to perform. You don't have to do anything except be there and be present and you're attuning to them, and that attachment system I'm sure is getting activated in many ways with you and as the person that's treating them and becoming that safety, that connected resource. So are your clients engaging with this approach and gaining insight? Understand the bottom up is we're treating the body, which I love. I missed that component for years. It's been a game changer to add that into my own work. But you're engaging the body, you're also engaging parts work, which is insight oriented and people really taking a deep look at their behaviors and their systems. And so how is this all translating into healthy eating?
That's a really good question. So when clients come into my office and I'm asking questions, we're trying to figure things out. There's been times where I've been able to think in my brain, this is what's going on, and kind of be able to figure it out, but the client's not ready for it. The client's not in a place to be able to do the somatic work or to like going back to that yielding, they're not ready to just slow down. They have to still keep going because their system is just not ready to experience something different. And so sometimes it is, again, just being with the client until they're able to truly intake this information, to intake the nourishment of the information and metabolize it and digest it. I've done some of the work with clients where they've essentially performed the work. They have done it, but it's like they're doing it because I'm inviting them to do it and they feel like they need to say yes. And so they're not getting necessarily the benefits of it. In the trainings are typically 4 or 5 days long, and I got to experience being the clinician and being the client with partners. And in the trainings that I've done, it's been with dietitians and with therapists together. And so I've been able to experience it from the client standpoint. And I truly put myself into the position of the client, and I was able to experience some of the benefits of it by doing these somatic movements. The purpose of the somatic movements is to uncouple the things in our nervous system that never meant to be coupled in the first place, and then reorganizing them and releasing what doesn't need to be there and then keeping what needs to be there. And so, for example, there was one time where I was doing one of the movements with the partner, and I felt this energy starting at my feet, and it went all the way up my body, and that was just my nervous system releasing something. It's really actually pretty neat, pretty cool. There's times too where I was the clinician and my partner was doing something and their nervous system shifted and I could actually feel it in my body. Sometimes there can even be an emotional release that happens. So a lot of times though, like I was saying before, that the clients just aren't ready to do it, and so it's still being in relationship with them. But the idea is that if they've had an attachment rupture, attachment ruptures that happen in relationship, and by doing these specific somatic movements in relationship with a dietitian or with a therapist that's trained in embodied recovery for eating disorders, then it is repairing the rupture, and that over time they're just able to start to eat more and eat more normally for them.
A couple points that I want to go back and highlight that you mentioned was there's so many nuances to this. We're all born with different genetics, different resiliency factors, generational epigenetic trauma. We don't fully know what's happening in the womb. I may be born in an environment where my central nervous system is well equipped for, and another may not. It's like all of these variables coming together to result into an eating disorder versus I want to look a certain way because the culture tells me to.
And we can attach to our caregivers. We can also attach to our peers, and we can attach to our religious affiliation, and we can also attach to society. So there are some individuals that are attached to diet culture, and it's
Okay.
literally part of of who they are. A lot of times though, if you look back in the person's life, there's still those attachment ruptures with their attachment ruptures that happened earlier in life. And that's why they attached to diet culture. So again, it's taking a look at every single thing.
How long are people generally in treatment with you?
It can last for a couple of months to years. Along with this new approach of embodied recovery for eating disorders, I also do work on food intake with people if they want to. So sometimes clients that come to me, they may literally want to just talk about food. And so again, with the trauma-informed approach, we'll do what they want to do with whatever shows up is what we'll do. So for some clients, it might just be a couple of months, but most clients, it's a little bit longer than that. Like I said, it can be anywhere to years.
And so, are you, traditionally, when I would refer people to dietitians, that's what I was thinking, right? Like that you were going to be taking blood work, you were going to be seeing how the body is functioning and checking in on different eating habits. So that's really just a very small part of what you do. Yeah, okay. And so tell me, when we're treating eating disorder clients, a lot of times someone will refer to me to do like EMDR trauma work, and then there's a dietitian, and then there's often an eating disorder specialist, but it almost sounds like you're doing it all in one.
Well, there is a fine line between someone who is trained in embodied recovery for eating disorders what an individual can do and what they can't do. So the trauma work I cannot do. I absolutely cannot do. I don't have training it. I don't have understanding, and I know this is the line of it. There is somatic work that there's no words involved of yielding and of some other movements that we can do in relationship, but that there still is that trauma work that they need to do with a therapist. So I just want to name that the
Okay.
exile from internal family systems, the exile parts. That is for a therapist to work with, not for a dietitian with these trainings and other things. Because dietitians can also receive trainings in different therapeutic techniques such as RODBT or somatic experiencing. And so a dietitian who goes through, for example, the somatic experiencing process and does it all, their scope of practice may be different. But for most dietitians with more training in these other modalities, there is this fine line of where a dietitian can and cannot work. And I just want to name that I am very, very clear of that. And that is the work of the therapist.
And for people who may not understand that language, and so what we're talking about with exiles are parts of self that are holding the traumatic events and all that goes with them, the sensory parts of it and the cognitions. And so what I'm hearing you say is that for a dietitian of your training is your work, you're engaging the body and releasing the energy and what I would call trauma out of the body, but not necessarily the psychotherapy work of reprocessing trauma.
Correct. Correct. Thank you.
Okay.
You put that so beautiful. Thank you so much for doing that.
So there would be a need to continue with a potentially a trauma therapist, but maybe not necessarily an eating disorder specialist, or yeah.
Yeah, it just depends. But
Okay.
sometimes a trauma therapist can help out with just what the client needs, and sometimes the eating disorder specialist that's a therapist is more of what the client needs.
Got
It
it.
still is important to have a therapist on the team.
What's the ideal team, Rachel? If somebody were coming to you with a pretty serious eating disorder, what would be your recommendations of a treatment team?
Having a dietitian, having a therapist, having a medical doctor, and possibly having a medication provider that may or may not be the medical doctor.
Okay.
Sometimes having an occupational therapist or a speech therapist also. Physical therapist can be beneficial too.
Why? Why a speech therapist?
For example, for a kiddo who has the ARFID, speech therapy can help with textures of foods. OT can help with
Okay.
that too.
Okay. Okay. Got it. So, how does this get paid for? Are you private pay only? Does insurance cover this? How does this get funded?
That's a great question too. So insurance covers dietitian services. My practice, Nourish to Flourish, we are in network with most major insurances. I'm in network with most of them except for Anthem. But most insurances pay and they sometimes there's a copay, sometimes very well, I don't say very rarely, but sometimes there will be a deductible. It just depends on the individual's insurance plans. But insurance does pay for this stuff now.
What if it doesn't? What if somebody has Anthem and you aren't covered? What are your private rates?
So for an initial session is 180 and follow a 1 hour follow-up is 140.
As therapists, we can provide people sometimes with super bills and they can go file themselves. Is that an option for your clients?
Yes, absolutely. We provide the super bill also.
Thank you for just taking the time. I'm going to step back and really process a lot of what you've said and try to better understand this approach that you're using. But if anybody wanted to find you or get in touch with you, how would they do that?
You can check out our website, which is www.nourish to flourish rva.com. You can also Google search my name and I'm sure it would come up.
Okay. Is there anything else you would want a listening audience to know about your approach, eating disorders, anything?
We just love to help. And even if the approach that I'm trained in isn't what you feel like would work for you. We have other eating disorder trained dietitians on staff and we just want to help.
Well, Rachel, thank you. This has just been lovely and just an honor to spend some time with you. Thank you for what you do, helping people, and particularly this population that really does need the right team. Again, just thank you. Thank you for your time.
You're welcome. Thank you for having me. I hope you have a wonderful day.
You too.